Yes, sir. We are. Thank you.
Good evening, everyone. My name is Dr. Neha, and I'll be presenting the long.
Ma'am, please go
So, my
ahead. Ma'am, please go ahead. Thank you.
border, both non-consanguineous Marka and residing in Mankhurd, Hindu by religion, brought by and informed by mother, being reliable, of fever since 2 months, on and off, two swellings noticed in the left inguinal region since 1 month, swelling in the neck since 15 to 20 days, pallor noticed since 3 days, and paleness of the body noticed since 3 days, and cough since 1 day. The child was apparently all right 2 months ago when the parents noticed fever, which was mild grade, 1 to 2 spikes per day, undocumented, relieved on medications, active during interfebrile period, not associated with chills or rash or rigor. A swelling in the left inguinal region, which was initially coin sized, firm in consistency, non tender, no redness, no progressive increase in the size was present. And 15 to 20 days later, they also noticed or felt multiple swellings in the neck bilaterally, which were also non tender and firm in consistency. There's history of loss of appetite since last 1 month, history of documented weight loss 7 kg in last 1 month, 1.5 months. There's history of bony pains present predominantly in the lower limbs, and there's history of generalized weakness present. There is no history of night sweats, no history of corpse contact, no history of any bleeding manifestations, petechiae or purpura. For the above complaints, the child was taken to DY Patil Hospital and admitted from 21st of June to 23rd of June, where some blood investigations were done and blood transfusion was given twice, and was advised for some invasive investigation related to the bone. But due to affordability issues, they took discharge against medical advice. At home, the child was apparently alright till 3 days ago when the parents noticed increasing paleness of the body. Along with it, she developed fever, which was high grade, undocumented, not associated with chills, rigor, or rash, and cough, which was non spasmodic, occurring in bouts, non productive, and brassy in character. There's history of decreased oral intake and history of decreased urine output since last 2 days. There's no history of any increased work of breathing, no history of any edema, no history of abdominal distension, no history of any dysphagia or change in voice, and no history of any blood transfusions received in the family. Antenatal history. It was a registered pregnancy. Iron folic acid supplements were taken, and injection TT was also taken. ANC scan at 8 months of gestation was suggestive of query decreased blood supply to the fetus, uteroplacental insufficiency. There's no history of any gestational diabetes mellitus or pregnancy induced hypertension in the mother. Birth history. The child was a full term, cried immediately at birth, vaginal delivery with birth weight of 2.13 kg. There's no history of any NICU stay. And the child is immunized till date. Developmentally, the child goes to school, studies in fourth standard, and has achieved all age appropriate milestones. Dietary history. The child eats from the family pot, mixed diet, and consumes 5 out of 7 food groups with a calorie deficit of 400 kilocalories and protein deficit of 11 gram proteins. The family belongs to lower socioeconomic class as per modified Kupuswamy scale.
Okay, so let's start analyzing. So you have a 5-year-old child with fever since 2 months, and this is the description of the fever. So what are your thoughts about the fever?
So the fever is mild grade only. It is not so significant enough to immediately seek any medical attention, or not so severe enough to warrant any attention over.
Fine. So that is fine. It is mild grade only. Is it documented, undocumented? So now what are your thoughts? As in thoughts means this is a very standard approach whenever anybody comes to you for fever. What are the questions in your mind when somebody comes to you for fever?
Fever has not localized over since
You're
1 month.
talking of this
This child.
child. So first tell me, what are the questions in your mind? Common sense questions when any patient comes to you with fever. No, what do you want to decide at the end of all, at the end of history, examination, everything? What do you want to decide?
There's cause for the fever.
So find the cause, and the cause can be, what all can it be? Groups, infectious, non-infectious, within infectious, bacterial, viral, tuberculosis. So the same thing you have to start answering from that history point. So when you are taking history and analyzing the history of fever, you have to start answering the same thing in your mind. Your order and probabilities may change over time as things get added on. So in that context, I'm asking, what is your interpretation of this low grade undocumented fever for 2 months?
Maybe duration of the fever is widely spread over 2 months, so there may be some chronic infective etiology also.
Okay. So you are saying that one possibility is a chronic infection. Next, any further interpretations? Then we will try to get deeper into those interpretations.
More of inflammatory than infective.
Why do you say that?
Because it is non-localized, mild grade.
So non-localized mild grade to fever, low grade fever often on is classical of tuberculosis, no? So that's not a strong reason to say it is inflammatory. And on the other hand, I will argue inflammatory fevers are often high grade, like your collagen vascular diseases.
Other association that it is not associated with any rash.
When did this lymph node come up? This linguinal swelling come up in the story of fever? So for 1 month, there was only mild grade fever. So let's stop there and talk. So there's nothing else now. So now what do you getting what I'm saying? So one, you said chronic infection possible. You said chronic inflammation. Anything else? Is it acute lobar pneumonia? So Baba, say na ke bacterial infection is ruled out. Learn to have that confidence that if it is 1 month low grade undocumented, bad ruled out. What about viral infections?
Acute viral infection usually subside within 7
You don't
days.
have long viral infections. So can it be those long viral infections? Can it be which virus?
HIV.
HIV. Then EB virus. Can this be that? So monosymptomatic, just fever and nothing else, is very unlikely for a viral infection. How do we describe viral infections? They have dash manifestations, generalized or multiple manifestations. Okay. So only fever, less likely. So what I'm trying to say is, try to develop this habit that out of your big categories, decide कि okay, this is out. Now I'm narrowing down on these one or two or three, and then we further debate within those two, right? So we have come to chronic in The other things are yet to happen.
How is the child for the 1 month duration would decide?
You're looking at what? Loss of appetite, loss of weight. So in between these two, will it happen more in one particular category? As in, how will chronic infection differ from chronic inflammation when it comes to loss of appetite, loss of weight, whatever?
The chronic inflammation could have the loss of appetite, loss of weight way earlier, means in a shorter amount of duration as compared to chronic infectious one.
I think 1 to 2 spikes per day makes me feel that it may not be low-grade fever. There is a spike coming in a low-grade fever. Right, whatever. So just you could have asked further, and what do you mean by spike? Spike generally means sudden worsening, and that could be moderate. If it's moderate, then one type of bacterial infections can produce moderate fever. It's a partially immune vaccine to which he has either a waning immunity or he has not developed adequate immunity. So, okay, and keep that keep that in mind, and therefore you could have asked, have you taken vaccine? Okay, so this is just extending further how a bacterial infection could present with moderate fever, but not a typical ladder pattern, high fever, etc. So that's one. If you look at, if the host is very poor immunologically, and a common host is a malnourished child, then he may also not respond the way a typical standard high fever should have come up. So we keep that in mind. Okay. And then the third is non-infective inflammation. Two major groups. One is the rheumatological and another is a malignancy. Now, between the two, rheumatological chronic illnesses may not even have fever at all. They may have some joint going on for a long time. And those who come out with fever have something to come up. High fever is unlikely. High fever is most likely, but soon there would be evanescent rash in esophagi or something else coming up, skin rash, joint, etc. One that present without it is a chronic rheumatological disorder, which present not with fever but some localizing thing. So this has to be malignancy. Now the question is, malignancies have a wide spectrum, and malignancies are of different grades. For example, semi-malignant disorders are histiocytosis, sarcoidosis. Okay. Whereas the typical malignant disorders are leukemia, lymphomas. So even they have a wide spectrum. Somebody comes suddenly, somebody goes on slowly. So very likely, this is one of the malignant disorders, maybe sarcoidosis, whatever, because there are lymph nodes. And I think that is where we start looking at this. Could it be a neuroblastoma? Another malignancy in pediatric practice which starts with fever. Usually high, yes. Usually younger children, yes. Could it be that? Generally, it is some fastly progressive. And most of them are diagnosed only when there are secondaries in the bones. So this is not that kind of a thing. So if you look at malignancy in pediatric practice with fever, you almost go down to leukemia, lymphomas. Okay.
So one word of caution, sir said that spike would mean moderate. Now I know, pardon me for saying this, but you residents misuse the word spike. So any fever spike, you don't necessarily mean that spike means a sudden upward trend, right? So what do we learn? We need to take a still detailed history and try and find out whether the fever really goes up, whether they need to give medicine or it is just a of being warm, etc. Right? And then not use the word spike, okay, because it gives a wrong meaning. Secondly, we've talked of this earlier also. When there is low grade fever, it is almost impossible to get chills and rigors. So mention it. Okay, when you're talking of low grade fever. Fine. So that is about the fever. Now, history of loss of appetite. So lymph nodes, we've already said, sir has discussed what lymph nodes could be. Now, history of loss of appetite and document loss 7 kg. So what's your comment on documented weight loss? Means what are your thoughts?
More than 5% in very short weight. More, but it's like within a span of 1.5 months. It's like very significant weight loss.
This is so very, very significant. There's no question about it. So where is that 5% thing? What is the importance of that 5% thing? Again, try to understand everything. Don't just memorize.
More than 10% within 3 months of duration.
5% within 3
3
months. But why that number 5% has been given? So if you are seeing a 1-year-old, then 500 grams of documented weight loss is important. But if you are seeing a 12-year-old who's weighing 60 kg, 500 grams may mean nothing. It may just be a weighing machine error. So that is why 5%. And what we are trying to do is you are trying to decide at what level you will consider it significant. So that 5% is to be discussed when you are on a yes, no situation. This is the very, very stark weight loss, right? So what does this mean? Means I am saying between malignancy and infection, what does it mean? And then otherwise, tell me top 3, 4 causes of big weight loss documented in pediatrics.
Tuberculosis,
I want something before tuberculosis.
malignancy,
I want something before malignancy.
HIV. HIV.
Malnutrition doesn't lose weight. They don't gain weight.
HIV.
HIV. How common is HIV in pediatrics?
Diabetes.
So your topmost cause should be diabetes. Okay. Next. So almost both endocrine problems, diabetes, thyrotoxicosis. Tuberculosis, yes, but tuberculosis doesn't always have weight loss. In fact, there is one related corollary that on treatment, suppose somebody is well treated, but it doesn't. Are you worried? You're worried, right? He's treated well, he's better, his symptoms are gone, but he has not gained weight. Depends on did he lose weight when the illness was there. So if he didn't lose big weight, he's not going to gain big weight. Lose weight during the process of your diagnosing tuberculosis in that 1 month, 2 month, then obviously on treatment he'll have very obvious weight gain, right? So these are the issues about weight gain. So here malignancy versus infection.
Malignancy.
Okay. Why inguinal lymph node to begin with?
But this came with inguinal lymph node. So comment on that.
You see inguinal lymph nodes very commonly, no? In children or adults, where do you see? Adults. Why? Means you pass it off as normal also. Why?
Genital and lower limb infections. So usually have.
So injuries, infections, whatever. So now sir is asking here, why did this disease start with inguinal lymph node?
I think there is nothing different whether you start with inguinal or I think primarily, unless it's a primary complex. Primary complex, the lymph node has to come from that draining area. Okay, like a hilar lymph node. Okay, cervical. Cervical TB is common. Where is the primary? Hilar is lung. Cervical, where is the primary? It has to be primary complex. So where is primary? And primary is in the tonsil. Okay. And primary focus is not seen. So you see only this. So it is unusual that you have any other lymph node coming as primary. Okay. So this must be a visible manifestation of a disseminated lesion. For all that, he may have started with an abdomen, he may have started with mediastinum, and therefore you could have started asking at that time, do you have cough also sometime? Which might say that, oh, it could have started with mediastinal problem or any pain in abdomen, etc. The point I'm making is that inguinal, as you said, noticed first, it could be, but the conclusion is it is one of the sites of a disseminated lymphadenopathy. And therefore, looking at that, we might anticipate that it is already spreading through lymphatics. But we are not visible easily, right?
Just one more point to add. When you talk about weight loss, we spoke of two endocrine conditions. Though much rarer than these two, Addison should be kept in mind because they present in a similar way: vomiting, feeling extremely tired, and loss of weight. So, plus, it is as dangerous to miss Addison both. Thyrotoxicosis, you will still have time to diagnose, maybe in the next day.
Okay, now you said history of bone pains present. Exactly, that was my question. How do you know it's bone pain? So on history, asking for bone pains is tricky. So what did you exactly ask and what answer did you get? So we'll learn again, okay, what is how to take it.
I only asked about the joint pain, like if she has any particular joint pain on the lower limb. That's it. Not
So don't use the word bone pain. You can one part of the limb. Later on examination, you will be able to decide whether it's any particular anatomical structure.
Joint pains makes it rheumatological. We're just saying that there would be something in the joint. Yes. What's your comment on that? We are going away from malignancy.
Mets to the bone can also lead to bony pains. मतलब joint pains, like metastasis to the joints can also.
Leukemia and arthritis commonly mimic each other. Joint, but it may be any part of the bone around the joint. And I think anybody who suddenly starts talking about joint pain, so if there was a swelling, then it's likely to be joint. Okay, if there's no swelling, then it's likely to be even leukemia. And leukemia and joint says, be careful, don't give steroids, you will flare up of something, right?
Why does leukemia gives bone pain. Why do you not get joint pain in leukemia? Or let me ask you a simpler question. Do you get bone in leukemia? And corollary question is, which other conditions can give you acute severe bone pain? Where do you check for bone pains? Shin and upper part of the shin, correct? Where else? Sternum. Oh, why these two places? Think superficial. Okay. So what you are checking is the infiltration of cancerous cells in the patient's bone marrow, and then thereby there is pressure in the marrow, and these are the areas which are superficial and will give rise to pain. Conditions can give pain, not malignancy. Scurvy. Okay. Any hematologic? You have two blood transfusion histories over here. Sickle cell. So there are some other conditions also like bone cysts, malignancies, etc. But commonly when somebody complains of bone pain, it's also unusual for them to complain bone pain in the lower limbs. Usually you get complaint either here or you get in the upper limbs, but not so easily on the lower limbs.
Would you have given a blood transfusion to that child? And could it be dangerous in any way? Unless there was a seriousness, child was in shock and all, you had to do it. But probably this child must not have been in shock. So there may not have been apparently an emergency to give a blood transfusion. So my question is, can blood transfusion given to this child can put us in danger when we are thinking of a hematological malignancy?
It can precipitate tumor lysis syndrome.
Okay. She said it can precipitate tumor lysis syndrome. Anything else? So I just said, right, that you don't give steroids when you're suspecting ALL. Similarly, you do not give blood transfusion, you are suspecting ALL. Diagnostics also, but it can also push.
It can cause hyperviscosity.
It can actually induce remission, temporary remission, and then you will have a relapse situation with a much worse prognosis when you start treating ALL after proper diagnostics.
This high fever which came up is how many days back? Just 3 days. So 3 days of high fever and that non-spasmodic bouts brassy cough. So what do you make out of this?
Any acute infection that has occurred.
So it could be a incidental acute infection. What acute infection?
Lower respiratory tract infection.
Yeah, so brassy cough is, where is the anatomy? Upper larynx. Yeah. So usually if your brassy cough is right, then you definitely have laryngitis for sure. So whether it is just, I mean, it's croup or laryngotracheobronchitis or what, we don't know. And usually in those, in viral, the fever doesn't continue to be high for many days. It starts as high fever, then quickly settles down. So again, these things have to be asked in detail. Could this be related to this whole picture? The whole, what we are thinking, probably a malignancy involving lymph nodes. Could this be related?
The cough can be because of lung metastasis.
Little more specific, lung metastasis or something better.
Pleural.
So what kind of cough does pleural disease give you?
Dry type of cough and pleurisy. No.
No, pleural disease gives you what kind of cough? we are saying this is brassy cough. So pleural disease gives you brassy cough. So we already said if brassy is right, then it is related to the large airways, larynx or somewhere there.
Compressing the lymph node
So
compressing.
lymph node pressing on the large airways is a possibility. You just stretch your imagination. Now, whether it will come up so acutely in 3 days, all that depends on your accuracy of the history also. But keep that also in mind. So both unrelated incidental illness and related to the disease, what could be both possibilities?
3 days of febrile fever off and on, TB. How can malignancy get better? 3 days of febrile at home. So they waited at home, right? Do you think malignancy behaves like that? So it must be TB only. I'm just trying to see whether you are all awake and you are listening to what Tushar said just 2 minutes ago. Yeah, okay. He could have gone home and come after 2 weeks also. This is what must have happened. Like giving steroids. Okay. So that's the danger. See how this child has behaved. And this will remind us all the time that before giving steroids or blood, we will give a thought. And in fact, hematologists tell us that don't give blood transfusion if possible. Okay, there are many dangers, right?
Dr. Mamta Manglani's quote, I remember she was your head of the department for years. The best blood transfusion is the one which was not given. So,
5-year, 10-month-old girl, first by birth order, born out of non-consanguineous marriage, who came with the complaints of fever, with anemia, with cervical and inguinal lymphadenopathy, with normal ANC and birth history, who is immunized till date, developmentally appropriate for age, is most likely a case of first differential being malignancy. On examination, the child was sick looking, febrile, with a temperature of 38 degrees Celsius. Pulse rate was 148 per minute. Respiratory rate was 32 per minute. The saturation was 99% on room air. Peripheral pulses were bounding. Extremities were warm. BP.
BP and pallor. So, analyze this.
So the child is febrile. The tachycardia could also be due to the child being febrile, or the child, since the child has pallor, it could be due to congestive cardiac, like a failure sign.
So, is there anything in this which is pointing to that?
The peripheral pulses are bounding.
Okay. Which means what?
It is a congestive overload state over
Hyperdynamic
state.
circulation. Possible causes of hyperdynamic circulation?
Anemia.
Anemia, high fever. Okay, fine. Then anything else is there in these vitals which you need to look at?
The respiratory rate of the child is also more.
Respiratory rate is 32 for a 5-year-old child who is febrile. But something more important. You want to look at the comparison of the respiratory rate and the heart rate? What is that telling you?
It is disproportionate.
What is higher?
The heart rate is higher.
So the circulation is on load. So at least you can make out that this is not just due to fever. There is an additional element which is causing a tachycardia, right? Anything in the BP? Wide pulse pressure. So make a habit of noting all these things. Okay. So just like we tell you history, every bit is important. Examination, every small examination, start interpreting. What is it telling you? Go ahead.
Hypertension has a wide pulse pressure, isn't it? Systolic has gone up, diastolic has remained nearly the same. Systolic hypertension, wide pulse pressure. So anemia, high fever, and hypertension. Three causes of white pulse pressure. You agree, no? If you see an adult ward, he may have 160 by 90. Okay, something of that kind. So first tell me, what is wide pulse pressure? How wide would be a wide pulse pressure?
Here, what is the difference? The difference is 44 and 4, 48. Yeah. So 48 is, yeah. Yeah. So by that definition, no. I agree.
Wide pulse pressure is a lowering of diastolic pressure, not just the wide pulse pressure. Lowering makes it wide.
-14.2 kg, which is falling between -2 to -3 standard deviations. The height is 103.5 centimeter, which is -2 to -3 standard deviations. And the BMI is 13.26, which is falling between -1 to -2 standard deviations. The impression is underweight and stunted.
Based, sir is asking that your history is of 2 months. If we were to look at this anthropometry, analyze anthropometry and decide whether there was a hidden illness earlier which has already started affecting the growth. In 1.5 months, so you can't have so much affection of the growth, no? 20 kg ka 14 to, but you are saying he lost 7 kg. So he was documented 20 or 21 kg some time back. Okay.
The height of the child is also 103.5 centimeters.
Correct. But height 103.5, what is your comment for this age? And 115 for a 5-year-old is a bit too much.
5 year, 10-month-old.
Okay, 6 years. Okay. So, you think he has lost height in this 1.5 month? He's not, right? So, how do you interpret that 103.5 for a close to 6-year-old? And then you interpret the weight and then you tell us what are your thoughts.
He has not gained adequate height since 1 year. Around his height age would be around 4 years, 4.5 years. And but acutely he has lost more weight. So illness might have started chronically, but uh, it has affected so much in last 2-3 months probably.
So see, we have to be very careful. These are all tricky situations. So first thing is understand that in height, it is never, it will happen that the height button is switched off. So if you are saying that height was, this height is of 4 years or 4.5 years, whatever you want to say. So even if you say 4.5 years, it can never happen that at 4.5 years, height button switched off, no more height. It doesn't happen that way. It means that height started getting affected much earlier, started slowing down. So instead of the normal speed, if you was growing at half the speed, And if this process started at 3 years, then by 4.5, what should have been 6 year ka height became, by 6 years, what should have been 6 years ka height became 4.5 ka height because he slowed down. Have you understood this process? So always for height, you have to analyze this. But the problem here is that we lost 7 kg. So if that is true, and he was 21 kg 1.5 months back, then this process of losing height from 3 years and becoming slow and all is all irrelevant, right? So therefore, it almost means that this is a normal height for this child for whatever reason, genetic, familial, constitutional. And there is only acute weight affection due to the disease. 2.1 birth weight, yeah.
It is not that disease started very early. We superficially might have looked at that disease started even a year before, but that's not true. And therefore, we come to conclusion that yes, history must be reasonably right. Even then, the length is or height is much less than what we would have expected.
Head to toe examination. There's mild periorbital puffiness present, depressed nasal bridge, cervical, multiple subcentimetric to 1 centimeter lymph nodes are noted in the bilateral region, cervical, level 2 and 3, and matted lymph nodes at level 2 on the left side. There are two ecchymotic patches, 2 into 2 centimeter over the abdomen. The abdomen is distended more in the upper half. Inguinal lymph nodes, the left inguinal lymph node is 1.5 to 1.5 centimeter, soft, firm, non-tender, and right subcentimetric inguinal lymph nodes are present, and rest is within normal limits. Per abdo system examination, inspection, the abdomen is distended more in the upper quadrant and moves uniformly with respiration. There are two ecchymotic patches seen. There are no scarce sinuses or dilated veins, and genitalia is normal. On superficial palpation, there is mild tenderness present in the right hypochondriac region. On deep palpation, liver is palpable 3 cm below the subcostal margin, which is firm, smooth surface, rounded margins. And left lobe of the liver is not palpable. The liver span is 8 cm. The spleen is palpable 6 cm below the left subcostal margin, firm in consistency, smooth surface. Tympanic note is heard over the abdomen and bowel sounds are heard. And the rest of the systemic examination is within normal limits.
Presented very well, Doctor. Just one small thing here is that don't write hemic murmur. Okay, that's your interpretation, well accepted, but try to say, describe the murmur, and then let them ask, or in your interpretation, you mention it's hemic. One more point here is, suppose we didn't have a history of 7 kg weight loss. You know that weight and height both are -2 to -3 SD. So we are looking at what? Mild, moderate, or severe. What kind of affection we are looking at? Moderate, correct? Now, how do we know whether weight is affected more or height is affected more between the two? Both are in -2 to -3 range. Any thoughts on that? No, we have only this much information. You have no other information, and we will not take any other factors into the parameter. So now there is only one more thing written over there which can help you, and that is BMI. Excellent. What is BMI? Body mass index. What does it tell you? What does it represent? It represents weight for height, correct? So now if you see that BMI is -1 to -2 SD, that means weight is more affected than the height. Okay. So though both have moderate, you can make a judgment by looking at the BMI that it is weight is more affected here than the height. And then we can debate about the causes. Okay. Okay.
Now, two questions. One is on examination, whatever you got, interpret that. And second, how does it add to your analysis after history? Okay, again, this is just a general way of approaching all cases. So interpret what you got examination. what did we get and what is the meaning of that?
Right.
Chalo. Everyone speak. Everyone we have to learn.
Periorbital edema, that is overload that we were thinking about during vitals. So that can be pointing towards overload. Then liver and spleen enlargement is there. So abdomen distended, so liver, spleen is palpable, and hematological cause can be there. Ecchymotic patches are there, which also points towards some hematological cause to it. And
Better word than hematological.
bleeding.
Bone marrow involvement.
Marrow
No?
involvement.
This is very clearly a bone marrow involvement, right? Okay, fine. Now tell us that what has it added to? So you had two DDs.
Something has not been said yet, or did I miss it? That's why I went to the next slide. Bone pains. Bone pains. Because I was looking for those bone pains. You got history of bone pains, no? So we'll need to confirm that.
So we had two DDs after history, malignancy and tuberculosis, and you said malignancy first. So now after these findings, what do you think?
Malignancy.
Why? I thought disseminated tuberculosis. So what? Tuberculosis disseminated to the bone marrow also. Disseminated, no, it can disseminate anywhere. So I want you to argue properly.
Hepatosplenomegaly, the ecchymosis, mainly we point towards pathological disorder than tuberculosis. And and
Presenting failure less, most what less than malignancy chances.
weight loss of 7 kg in 1.5 months is not likely of tuberculosis.
Pallor requiring blood transfusions is also not very common.
That's it. I just wanted to say if there were no ecchymosis, would you have thought of tuberculosis? But you already answered with the other supporting one.
Who gets disseminated tuberculosis? Undernourished host. We discussed that this was a very good host to begin with. Okay. And then so much dissemination just in 2 months and all. It's not possible.
There was a matted lymph node. That is typical of TB. You get in leukemia also matted lymph node. And why? What is matted lymph node?
There are multiple lymph nodes enlarged, and there is a addition between the two lymph node. Um, there is addition, so matted is there, sir. Otherwise, it is not specific for tuberculosis.
Is periadenitis, which makes them stick to each other, which is not specific to tuberculosis. Okay. Thank you.
Impression: 5-year, 10-month-old girl, first by birth order, born out of non consanguineous marriage, who came with cervical and inguinal lymphadenopathy, with severe anemia, with ecchymotic patches, with hepatosplenomegaly, with congestive cardiac failure, with normal antenatal and birth history, developmentally appropriate for age, immunized till date, with underweight and stunting, is a case of malignancy, first suspicion being leukemia more than lymphoma. So because of the part where the lymph nodes are not that comparatively enlarged, which should have been in lymphoma, and type night sweats and all associated symptoms are not present in it. The ecchymosis part, pancyte, other features of bone marrow. The investigations, complete blood count done on 20th of June for the pre-trans sample was suggestive for HB of 3.3, hematocrit of 9. The counts were 2,190 and platelets were 37,000. Pancytopenia was present, and the peripheral smear at that time had no atypical cells seen. 2 PRC.
So even though there were no atypical even though there were no atypical cells at that time, what would have been an alarm bell for you? Pancytopenia, and that's what Tushar is asking. Differentials. Look at the differentials of that 2190. Correct. So in that 2190, if you would have had more lymphocytes than neutrophils, that would also be a red flag, right?
Even without pancytopenia, if you had only absolute neutrophil count decreased in a given situation, that would be more concerning than otherwise.
Post the transfusion, the CBC was suggestive of HB of 7, hematocrit of 20.1. The WBC count was 2,760 and platelet was 40,000. On arrival on 7th of July, the CBC done here was suggestive of counts of 1,130, out of which the ANC was 500. The HB was 4.4. The hematocrit was 12.7. The MCV was 64.8. MCHC was 22.5. MCH was 22.5 and MCHC was 34.7 with platelet of 24,000 and the RBC count was 1.93 million. The peripheral smear was suggestive of decreased count, markedly decreased platelet count. RBC morphology was hypochromic microcytic, anisocytosis and poikilocytosis present, and blasts were present. The LFTs for the child was done on 5th of July. The total bili was 0.4. The SGOT and SGPT was 27 and 12. The total protein and albumin was 6.3 and 3.8. The PTINR was 18.3 and 1.62. RFT was 7 and 0.5. The serum electrolytes were within normal range, 137 and 4. The flow cytometry report of the patient is suggestive of BALL. Thank you.
ESR2, explain.
On the lower, RBC count was on the lower side, because of that the ESR was reduced.
Okay, good. Okay. We'll have the second case. Yeah. Come.
I'm presenting a case of 5-year-old boy, second by birth order, born of non-consanguineous marriage, resident of Nashik, Hindu by religion, Maratha by community, with informant being mother, who is a reliable source of information, was referred to our center for mainly investigation purposes and from periphery hospital. Child has significant past history. So I would like to start from there, from ANC history. ANC history में pregnancy was registered. Mother took supplements. 3 UHG scans were done for the mother, which were told to be normal. There was history of blood transfusion in mother in 9th month of gestation, just before the delivery. No history of gestational diabetes mellitus or hypertension or thyroid disorder in mother. There was no history of bleeding or leaking per vagina. There is no history of fever with rash. Birth-wise, child was full-term LSCS in view of delayed progression of labor in mother. Baby cried immediately after birth. Birth weight was 2 kg. There was history of PPH in mother, for which mother was kept in under observation. Breastfeeding was started within 12 hours of birth. There is no history of NICU stay, neonatal jaundice, discharge on day of life, fate. At home, At home, the child was feeding well, was able to roll over partially, and was able to hold it at 6 months of age. Then child had first episode of convulsion in form of sudden involuntary flexor movements of bilateral upper limb and lower limbs, resembling flexor spasms, lasting for about 3 to 5 seconds, which were aborted on its own. There was no history of fam dam. Child was playing before the event, and there was no history of PID also. Child used to have almost 4 to 5 episodes per day for 8 days continuously, which were of similar semiology. Parents didn't seek any medical attention until 8th day. Then he was shown to a local practitioner who referred them to a neurologist. Neurologist did a EEG, which was suggestive of hips arrhythmia. He was started on Siraplavera and Omnacotil, but there was no effective control of convulsions. And then he was shown to Pravara Hospital. So further investigations were done for the child. MRI and 2D echo. Clobazam was added for effective control of convulsions. Since then, the frequency and duration of the convulsions were decreased. Last episode, last episode of convulsion was in August 2024. Since last 2 years, seizure simulology has changed to tonic-clonic movements of the right side of the body and deviation of angle of mouth towards the right with frothing at mouth with uprolling of eyeball also lasting for around 5 minutes, which is followed by PID. Currently, child is on Levera and clobazam medication. Past history, there is a history of admission for MRI. Child is immunized till 1.5 year. Development-wise, gross motor, neck holding was achieved at 6 months of age. Rollover was achieved at 7 months of age. Child started sitting with support at 10 months of age. Walking was achieved at 1.5 years and running at 2 years. Fine motor-wise, child has hand regard at 4 months of age. Pincer grasp was present at 1 year of age. Child started eating without spillage at 1.5 year of age and started going toilet alone recently. Social domain में follows commands, but after asking for 3 to 4 times, he likes to play with peers. Language wise, child started speaking monosyllables at 1 year of age. Bisyllable at 1.5 years of age, 1 to 2 words at 2 years, and 3 to 4 word sentences at 2.5 years of age. Currently, child goes to first standard. There is a significant language delay and learning disability also there. Child consumes mixed diet, which has a calorie deficit of 100 kilocalories and protein deficit of 9. Uh, the family wise, the child stays in a nuclear family. Mother and father is a farmer. Child has an elder sibling, which is 10 years old, and is doing well. On examination, child was a febrile heart.
So how would you approach this child when this child was brought at 6 months for this one episode of sudden involuntary flexor movements. At that time, what would be your approach, your thought process?
It is a I would like to first rule out all metabolic causes for
Thought in convulsion state.
You're
So
sure it's a convulsion?
very, very.
That's the semiology of the event, sir. How was the child? How was the consciousness of the child? Is it a myoclonic? We should differentiate between myoclonic jerk or a convulsion. If the child is awake and eyes are open and there is no uprolling of eyeball and it is not generalized and only having jerks, then it might be a myoclonic jerk. Is a
Very
better
good.
thought.
So the first step is to define what that event is. And if it is fitting into whatever, a seizure or a myoclonic seizure or whatever, then the next step is to try and understand ki what could be the reason behind this, right? Then what will you do next? What will you think? What have you got so far?
It is short lasting without any post-ictal drowsiness.
Hmm.
So most it is looking like myoclonus.
So do you get myoclonus in metabolic seizures? I'm just asking because you are saying that it was short lasting and all that. That's why I'm asking. So I think that if you can make out the type that this looks like a myoclonic seizures, then all your other metabolic this that is very unlikely. So the next thing that you have to understand at this point is, or analyze at this point in your mind is, that doesn't seem to be any perinatal event either for this to be a remote symptomatic seizure. So that might tell you that this is the beginning of some neurological illness which is going to progress only further. And then add to that, you have some delay in milestones, which is kind of adding to that.
I think for every seizure, you must ask the preceding event, during seizure what it is, and post-seizure event. Here, obviously, possibly there was nothing pre-seizure, we believe so. Then during the seizure, if possible, where the eyes were open, okay, all that. Then post-event could be drowsiness commonly, sometimes even some automatism, lip smacking, some of those things, which makes us sure that we are dealing with a seizure disorder. So that is number one. Second is, in between those episodes, how does the child look like? Would he be feeding? Was he playing? Was he responsible? Okay, the way he was before all that. If not, then we already know that there is some brain function getting disturbed. But suppose somebody said that, no, no, everything in between looks all right. Then you start wondering whether you did really had a seizure or it was totally an abnormal moment. And I think all those details would make us sure, because there could have been some delay in between parents' notice if we had asked for it. That what was the child doing prior to the first event and what is he doing now, say after a couple of days of such repeated spasms. You might find that something is going down a little. Okay, does he look the same way? Does he smile? Does he laugh? All those. That could have said that this delayed development is already coming slowly, and at some stage you have that. All that we know is that it's not deteriorating fast. Okay, and I think a metabolic cause would have possibly deteriorating first and would not have this kind of a thing. Could it be an infantile spasm? That's the commonest spasm at that age, right? What's your comment on that? West syndrome.
After convulsion, there is usually crying.
Should have come up a little earlier, not necessarily, but generally by 2, 3 months, and then fastly progressive into more and more delayed development. This did not look like that. And that's the importance of find out whether how is the child in terms of development in between those episodes. That might have told us something a little better.
What was the reason for doing a 2D echo?
Sir, on actually what happened is on examination, child has neurocutaneous markers, so they suspected.
Which means that it could be some syndromic problem. And whenever you are considering a syndromic problem, you look at every other organ as well. So on examination, she has picked up something.
On arrival in wards, child was febrile, heart rate of 118 per minute, respiratory rate of 22 per minute, peripheries warm, peripheral pulses were well pegged, extremities were warm, BP was 90 by 70. Anthropometry wise, weight of the child is 17.8 kg, which falls between -1 standard deviation to 0 standard deviation. Height of the child was 117 centimeter, which falls between 0 to +1 standard deviation. BMI of the child was 13, which is at -2 standard deviation. So impression is normal. On head-to-toe examination, there were freckles present over cheeks and nose. Query answer.
ये इधर आइए. લોકો અહીંયા આવી જાય છે. Come ahead, come here. Chal, someone who has not seen the patient, so start commenting.
Child is comfortably sitting. It is well grown, like normal, well built child.
Rajesh, we cannot hear.
So every neuro case, when you're asked to do inspection, make it a habit to talk about presence or absence of dysmorphic features, head size. Okay, all these things are very relevant to every neuro case. So make it a habit. And then what is the general look of the
Child is conscious, active, interested in surrounding. Um, head circumference looks normal. Um, then over the back, there are some hypopigmented patches can be seen, like this one. And over the right flank, also there are some hypopigmented patches. With a picture.
they have any particular description, or they're just hypopigmented, or you want to add something? Vishal, लेना? Okay, go on, go on.
What else do you see? Shagreen patch. Okay. Capiole spots or hypomelanotic spots? Hypomelanotic. Ash leaf. Okay. How do you suppose you did not see but you strongly suspect? What will you do?
Would lamp examine.
And ask your dermat friend to do an examination under the Woods lamp. That also helps you differentiate between fungal and many other conditions, dermatological conditions. So all the stigma of tuberous sclerosis that you see, they are not always present at any given time. So at this age, you don't see periangual fibromas and sometimes the other problems. Early on, you will see the heart abnormalities. Later on, the atrial myxoma and things like that, which may not be seen that. That's why the echo probably was asked for. Head size says normal. No cataract. Any cataracts? No.
Ophthalmic examination is that there is one more hypomelanotic patch on uske right side ka finger toe. And one patch is also there on the knee also.
It's important to cover everything, but it's more important, say, for neurofibromatosis to see and count all the capiole spots. For tuberous sclerosis, it does not matter. You have one or two classical lesions, that's good enough. There could be more, there could be less. It does not make any difference in your diagnosis. But it's, at least from my whatever few cases I've seen, it's unusual to see the facial abnormalities so early in life. Usually you only see Chagrin patch and don't see this often. But anyway, it's good to see this.
Uh, child actually in unfamiliar surroundings, child should be thoda conscious about meeting new people, but he's very comfortable.
Sir, probably ask more from the point of view of whether it falls into autism spectrum disorder, etc. Also, because some children have many neurodevelopmental abnormalities, high risk for that.
Examination, CNS wise, higher mental functions were normal. Child was conscious, oriented to time, place, and person. There is no obvious evidence of cranial involvement. Tone and power were normal. Knee reflex is 3 plus and rest reflex is a 2 plus. Rest systemic examination is within normal limit. Impression: 5-year-old boy, second by birth order, born of non-consanguineous marriage with complaint of multiple episodes of convulsion since 6 months of age, immunized till 1.5 year with developmental delay, with learning disability, with neurocutaneous markers on face and body is most probably a case of neurocutaneous syndrome. My differentials were tuberous sclerosis, neurofibromatosis, and von Hippel. So this is the child got his first EEG report done, which was suggestive of hips arrhythmia. This is the first MRI of the child. Multiple asymmetric ill-defined areas of altered signal intensities in cortical. This is the first 2D report of the child, which was two rhabdomyosarcomas were confirmed on the exam on the 2D report also. Child was advised regular MRI follow-ups and echo follow-ups. USG was also done, which was suggestive of multiple cysts in kidneys and which were replacing renal parenchyma. Largest cyst size was 40 to 28 millimeter. These are some clinical photos of the child. Thank you.
What are you going to do next now?
As we all know, there is no curative thing for this child, so we have to go by managing the convulsion episodes, which is a priority. So child is convulsion free since last 1 year, so we have to just have to monitor and instruct the mother if any breakthrough convulsion occurs at home also. And then he has to be screened regularly for rhabdomyosarcomas by 2D echoes and regular MRI at interval of 1 year and all. Ophthalmic examination also. Yes. This is second one. First is normal.
Has any skin lesions, we can
Clinical examination should definitely be done for the other SIB. And counseling, what will you tell them? They may want the third child. Apart from family planning, what other things will you tell them? Any genetic?
Autosomal dominant, but can be sporadic also.
So that doesn't help me as a relative. It can be that, but it can be this. So what is there a risk? They will ask, what is the risk for my next kid having this? 50%. She's saying sporadic. So if it's autosomal dominant, not only in this case, generally for any autosomal dominant, screen the SIP, screen the parents. If any family member has, including grandparents, because autosomal dominants are known to skip generations. So you may not have, it's called non-penetrance. So they will not manifest in that particular generation. So then the risk may still be 50%. Okay, so it's easy to say for autosomal dominant sporadic, but you need to know. And amongst autosomal dominant, there are some conditions which have 100% penetrance. For example, achondroplasia. So if some kid has achondroplasia, parent has achondroplasia, 100% penetrance, so 50% chance of definitely going. Meaning they won't skip generation. That's what I'm trying to say.
Anything else? Any comments or questions from the online audience?
Just wanted clarification what anticonvulsant is going on.
What anticonvulsant is going on?
For her Levera.
Clobazam and Levera.
Okay. Because vigabatrin is supposed to be a good anticonvulsant for tuberous sclerosis.
Yeah.
And what was the MRI picture?
She read out there were some yeah, go back. Your screen was that report was very
Rajesh, if it's taking too long, it's okay. In the meantime, I'd like to take this opportunity that we are indeed blessed on Guru Purnima to have this clinic and to have Dr. Amdekar and all the other esteemed faculty here to tickle our gray cells. We have learnt a lot over the years, and this webinar brings us so much joy. Thank you so much, sir, and all others. Thank you, everyone, on our behalf. We cannot hear. Rajesh, we can't hear. Rajesh, we could not hear anything.
Ma'am, I think they left. Madam, I think they left. Shall I close the meeting?